Well, thank you very much. And first, I really do want to thank you for coming out to hear what we have to say about neuro-oncology. We're going to break tonight up into two sections. For the first 15 minutes, I will just fill you in on the brand new Marcus Neuroscience Institute. Some of that has to do with brain tumors and some does not. Then we will hear from me and from the august panel members about their area of brain tumor management and what that means to you. Probably the single most important thing I can say, however, is that despite the wonderful introductions that we just had, it would be much more important to realize that this is a single team. Okay? And what really distinguishes what we do here at Boca Regional and the Lynn Cancer Center and the Marcus Neuroscience Institute is that we are all developed around an interdisciplinary, patient-centric approach to the problems that we treat, and in this case, brain tumors. And so what we do in neurosurgery, we cannot do effectively without critical input from the neurologist, the neuroradiologist, the radiation oncologist, and we work together in real time as a team to approach these clinical problems. So this is our neuro-oncology team, and this is what anyone would access when they come to see us either at the Marcus or at the Lynn, which are basically across the street. And you don't get care from a doctor, you get care from the team. Let me speak a little bit about the Marcus Neuroscience Institute, and let me say that one of the great joys of moving down to South Florida is it's the first place in my life where people actually instinctively pronounce my name correctly. So that's a joy for me. I get so tired of trying to explain all of the different variations. But the Marcus Neuroscience Institute was founded first as a vision by Bernie Marcus, who gave us our founding gifts. And our concept is to be excellent in all areas of neuroscience patient care. And when I say excellent, I mean to be the equal or superior to any institution in the country, including the institutions where I came from, Stanford, UC San Francisco, Northwestern, and our other physicians come from MD Anderson, they come from Harvard, they come from Hopkins, and we will accept second best to none of those. We also have, as part of our charter, commitment to the institution and the community. Community service is what we're about. We also educate the medical students and the residents and the fellows of the medical school, and we are dedicated to performing clinical and translational research. And what that means to you is that not only you get the best available care for any neurologic type problem, but our doctors are on the cutting edge of developing new therapies and new approaches to some of these disorders that aren't treatable. And where we started have been by hiring the best physicians and researchers in the country, building a building with the best technology anywhere in the country. As you're seeing here today, our foundation is on collaborative, interdisciplinary care, not just for brain tumors, but for Parkinson's disease, for epilepsy, for all of the things that make up neurologic disorders. And again, it is a truly patient-centered approach to care. Within the Marcus Neuroscience Institute, we have the neurosurgeons, we have the neurologists, thanks to a very generous gift from Harvey Sandler. We have the named Harvey Sandler Center for Neurosurgery that I direct, and very soon we will have our director of an as of yet named Center of Neurology. And our initial programs of excellence include memory disorders and Alzheimer's disease. We have the Leon and Toby Cooperman Center for Alzheimer's disease, which works very closely with the Lou and Annie Green Center across the street. We have a Center for Spinal Disorders and Chronic Pain, Cerebrovascular Diseases and Stroke, Neuro-Restorative Surgery and Deep Brain Stimulation, which I'll explain in a minute, and the Center for Brain Tumor Therapy. And in addition, for each of those, we have our Center for Translational Neuroscience Research, that area where we are working on developing cutting-edge therapies. So just to march through these quickly, cerebrovascular diseases and stroke. It's a major problem in this community. There are now over 800,000 strokes in the United States each year, and brain attack is no different than heart attack. It demands immediate recognition and treatment. We are aggressively working with the community and EMS and the hospital to build new systems that allow us to effectively initiate the most state-of-the-art therapies to prevent a stroke before it happens and restore brain function when we can. We have Dr. Shay Moskowitz, who we recruited from the Cleveland Clinic. This is his picture, who heads our endovascular and open cerebrovascular surgery unit. He does coiling, he does clot retrievals, he does all of the state-of-the-art techniques that can be done through a vein, but also direct approaches on the brain as necessary. He and our stroke team has access to our own fast CT scanner that can get a CT scan outside of the emergency room within a minute. We have the state-of-the-art angiography suite so we can treat many of these problems without having to open patients' head. And we also have a chronic stroke program working with the building that is being built, the Gloria Drummond Institute for Rehabilitation. A large part of that is dedicated to helping us have rehabilitative programs for people who already have these problems. We also focus on research in this area, and some of my own research involves working on stimulating the brain to restore function to limbs that are paralyzed after stroke. So the whole spectrum of cerebrovascular diseases. Aneurysms, which are abnormal bubbles on a blood vessel in the brain, we can now treat either through the blood vessels or by open craniotomy, and we have wonderful equipment in the operating room that include computers and robotics that allow us to see within the brain before we operate and do very highly technical operations to treat these problems when we need to. We are recruiting our director of the new Philip and Nancy Deswerick Center for Spinal Disorders and Pain. This is what you see in most hospitals. It's called an O-arm. It's sort of a poor man's CT scanner. This is what we have in the Marcus. We have a brand new state-of-the-art diagnostic quality CT scanner on rails. So in real time, our spinal surgeons can know that they're doing the right thing the right way the very first time. And instead of just after the operation taking an x-ray and crossing your fingers and hoping that everything is in the right place, they have real-time CT computer guidance. So before a screw is even placed, before anyone gets near the spinal cord or a nerve root, they know exactly where they are, how to advance that equipment in ways that we can take care of the problem without causing damage. And many things don't require surgery. And this is one of the physicians we're currently recruiting who does minimally and micro-invasive surgery as a non-surgical way of treating many back pain problems. And we have a large program in what's called neurostimulation for patients where back surgery has failed and they still have residual pain that requires treatment. The Center for Brain Tumor Therapy is something that I run with Dr. Levine's assistants, and together in his area of skull-based surgery, which he'll talk about later, and in my area of more traditional neuro-oncology, we have state-of-the-art equipment and wonderful collaborators to allow us to care for these problems. I'm not going to go through the details of all of these slides, but what you can see is that there is an incredible amount of technology that allows us to know exactly about the nature of the tumor, not only its location, but even, for example, what important pathways run around the tumors so we can optimize the approach to more completely remove tumors without damaging critical brain structures. And perhaps most importantly, we have a brand new state-of-the-art 3 Tesla MRI imager. Make that the best imager you can get anywhere for humans, but it's hanging from the ceiling of our operating room. So in real time in the operating room, we can do scans on patients, know what we're doing, know if we need to take more of a tumor, know where we're safe, And what this translates into is more often cures and much, much less often complications of our surgery. We have the Center for Neuro-Restorative Surgery and Deep Brain Surgery, and most of the time this is done to treat patients who have movement disorders or chronic pain. We treat disorders like trigeminal neuralgia, a very severe facial pain syndrome that we can cure 90+% of the time with the appropriate treatments. We can map out the brain to know where untreatable epilepsy arises and know exactly what needs to be removed to cure the patient's epilepsy without injuring the surrounding brain. Chronic pain is a major problem. There are over 100 million patients in the United States who have chronic pain. We only have a population of about 350 million. And we spend about $600 billion, with a B, billion a year paying for chronic pain in the United States. So the impact that we can have on treating chronic pain is profound. My particular interest is treating migraine headaches as well, and for patients where migraine medicines and Botox don't help, we have developed multiple procedures that in 85% of our patients give them lasting relief of their migraine headaches. We know about where to stimulate in the brain to treat previously untreatable diseases. And again, typically it's chronic pain or Parkinson's disease, but there is work that's being done now where patients are being treated for severe depression that doesn't respond to medicines, obsessive compulsive disorders, and just recently stimulation procedures were approved last month for treating obesity. We know the targets for these disorders, but nothing speaks quite as well as seeing it for real. And you can see here, for example, this is a patient. Well, what you would have seen, and I won't belabor the point, is someone who walks extremely slowly, someone who has severe shaking of their arms, someone who falls over when they try to walk, and then 3 months later, somebody walking normally, shoveling snow in Cleveland, and functionally cured of all of the symptoms of Parkinson's disease with a simple operation such as implanting a wire in the right point of their brain. As I've mentioned, we are opening the Toby and Leon Cooperman Center for Alzheimer's disease and memory disorders. We are this week putting the ink on a contract with one of the international leaders in Alzheimer's disease who will change the face of Alzheimer's care in South Florida and will be jointly appointed by the FAU Medical School and the Marcus Institute, who will lead the research program over at the Lou and Annie Green Center on the FAU campus, and at the same time will run a large Alzheimer's disease clinic here. And again, by providing comprehensive interdisciplinary care, provide care for both patients and their caretakers in a way that we have never seen here before. In addition, he is dedicated to finding a cure to Alzheimer's disease and has a large research program dedicated to trying to find out what causes and how to treat Alzheimer's disease. And then, as I mentioned, an overriding center dedicated to research in all these disorders, and we've made tremendous progress only in the last few months since we've opened, and we now have a formal alliance of neuroscience research in South Florida that includes the Scripps Institute, the Max Planck Institute, and FAU, and together with the Marcus Neuroscience Institute, we have started the South Florida Neuroscience Research Consortium, and we're already applying for grants to build a large research infrastructure to support these studies. So who are the people who do this? Because these are the people that you'll interface with. Well, you can see in the back of the room there, Roanna Kingman is our administrative director. She runs everything and keeps things going so our doctors can do what they need to do. You've already met me, and I've mentioned Shay Moskowitz, who is our head of cerebrovascular surgery and endovascular surgery. You can see Dr. Nick Levine, who is our head of skull-based surgery and comes to us from MD Anderson Medical Center. You can see Dr. Patricio, or better known as Sebastian Espinoza, who, according to the man who trained him, is the single best neurologist he's ever trained. and has fellowships at Hopkins and at Harvard, who is a one-man department of neurology. And together, they are the first people to build the Marcus Neuroscience Institute. We will have 3 more faculty members on site by the summer, and the one I'm most excited about is this one. I'm trying to get him into medical school early, but he seems to enjoy video games too much. But I can say that, you know, he might want to go into psychiatry because he's really good at driving us crazy. Sleep disorders, he's already made both my wife and I profoundly sleep disordered, and so hopefully he'll be around when I leave. But as I've mentioned, we are just on the cusp of getting signed contracts from our stroke director, from our Alzheimer's director, and now the head of our spinal program. We have wonderful technology. We have a beautiful building that you've all seen on the campus here, but I'd operate in a tent if it meant that I could work with the kind of quality physicians that we have here to support us at Boca Regional, at the Lynn Cancer Institute, and the wonderful colleagues that we've recruited here. And as many of you may have seen the ads that Tom Shakurta, who's at the back of the room, put together for television in this area, but we really do try to live up to what that ad says, which is actually our motto, that we are changing the face of care for neurosciences in South Florida. So that's the Marcus Neuroscience Institute, and I hope that you will think of us anytime that you have a neurologic problem. Hopefully you won't, but you all know family members who might. Now, and more apropos, I get to kick off the talk about neuro-oncology. Okay? And what I found is that a lot of people don't know a whole lot about brain tumors. The sad thing is that having taught third-year medical students for 25 years at Northwestern, I found out that third-year medical students didn't know a whole lot about brain tumors either. And so there are a lot of basic issues about brain tumors that I'd like to walk through that then allow you to understand the kind of exquisite things that the other people on this panel do. And so, what is a brain tumor? Well, a tumor is simply a mass of abnormal cells, cells that aren't supposed to be there. And in the brain, they can be malignant, which in brain terms is sort of the same as cancerous, or they can be benign, which is non-cancerous. Benign tumors usually exert their effect simply by their mass. That is, as they grow, they push on something. And they can push on a nerve and affect that nerve's function. They can push on a part of the brain and affect that part of the brain's function. Or if they grow big enough, they can actually cause the pressure inside your head to go up and cause problems from that. Malignant tumors can do that as well, but they can also spread and invade the surrounding normal, healthy brain tissue and destroy that brain tissue. So most of the things that we do for benign or malignant tumors are very similar, but the difference is for the malignant tumor, we have to stop them from destroying and invading normal brain as well. In the world of tumors, brain tumors aren't that common. Now, we see about 150,000 brain tumors in the United States every year, but about 130 of those are in people who have cancer somewhere else in their body, and it's spread to the brain from the rest of the body. There are only about 20,000 what we call primary brain tumors each year in the United States, and about 30% of those are malignant. So the first thing you can take home is, if somebody tells you you have a primary brain tumor, doesn't mean it's cancer. It could be, but it doesn't necessarily mean that it's cancer. And of the primary brain tumors, we have what are called gliomas. They're the most common, and they're graded grade 1 to 4 based upon how aggressive they are. So they can be minimally aggressive all the way to severely aggressive. And a grade 4 tumor is also called a glioblastoma, but there's a broad range. Central nervous system lymphomas are also aggressive and malignant tumors. But the others are the most common: meningiomas, pituitary tumors, and what we call vestibular schwannomas, but you may have heard of as acoustic neuromas, tumors of the hearing nerve. Those are all benign tumors, and those are things that Dr. Levine will talk more about. The metastatic tumors, much more common, 120, 130,000 a year. Those almost always spread through the bloodstream. So if you have a lung cancer, some lung cancer cells can shed off into the bloodstream. They go to where the blood goes, and a lot of blood goes to the top part of the brain, which is called the cerebrum. And usually, not always, but usually, they're more than one. And most commonly, lung cancer, breast cancer, kidney cancer, or a skin cancer called melanoma are the ones that metastasize to the brain. Many other tumors only do it very, very rarely, but those four are much more common. What causes brain tumors? Well, I tell patients bad luck. And what that means is most of the time we don't really know. But we know that there are some things that increase your risk to brain tumors. If you've had radiation therapy to your head, that can increase the risk of tumors. If you've had radiation of any type. I have a whole population of patients that I've treated over the years who lived within 100 miles of Chernobyl in Russia. Then they moved to the United States, and it is remarkable how many of them have developed brain tumors over the years. In Chicago, I think I treated 30 or 40 patients who lived around Chernobyl. But also, for example, in Israel in the 1950s, they treated head lice with radiation. We don't do that anymore. But literally, they just line up all the school kids and blast them with radiation in their head, and it killed the lice. But 20, 30 years later, many of those patients developed tumors as well. There is a genetic component to many brain tumors, but we don't understand that genetic component as of yet well enough to effectively use it in brain tumor therapy. HIV infection can predispose to certain types of brain tumors, cigarette smoking, and there are certain environmental toxins that we know can lead to brain tumor development, particularly some of the chemicals that are seen in oil refineries, in rubber processing plants, and in embalming chemicals. So as we learn more and more, we'll understand more, but most of the time, the answer your doctor will tell you is, we don't really know why. What are the symptoms of a brain tumor? Well, remember, brain tumors either compress or, if they're malignant or aggressive, invade the brain. And so they can cause headache, nausea or vomiting, numbness if it's near the sensory area of the brain, weakness if it's near the motor area of the brain, speech difficulties, seizures, and a large part of what Dr. Espinosa will talk about is how brain tumors cause seizures in the brain and how to treat them. And a neurologic deficit. That is, depending on where the tumor is, if it's pushing on an area that does some significant function, you'll notice it. Brain tumors are like real estate. Location, 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 okay? And so what you have could be anything. And many times people will present to the emergency room thinking that they've had a stroke, but in fact they have a tumor. And so those are the things that alert us to the fact that a patient may have a stroke. And then how do we diagnose it? Well, the old school way, and I'm old school, is you actually talk to and examine a patient. And most of the time you can make the diagnosis with a careful examination. But nowadays we always follow it up with either CT or even more preferably with an MRI scan. We will hear much more about the neuroradiology and imaging of tumors. But then once we have that, then the gold standard, of course, is looking at the tissue under the microscope. Because everything in terms of treatment and prognosis is knowing exactly what type of tumor it is. And there's only two ways to get tissue. Either we do a biopsy, and you can do a needle biopsy, or you can take it out. Either way, you have tissue to look at under the microscope to then direct the appropriate therapy. What are our treatment options? Well, observation is one of them. And you may look at me and say, that's a crazy neurosurgeon who says, I got a brain tumor and I should watch it. But some benign tumors are very small, and they may not grow to cause symptoms within your lifetime. And what do we need to do to cause your problems by doing a big surgery when just by following it, we can make sure it's not growing? We can do surgery, and surgery can be anything from a needle biopsy all the way up to a full surgery to remove it. And as I've mentioned, we have the world's best equipment in our operating rooms to guide that. Radiation therapy is a key part of treating brain tumors. Many times for malignant tumors, the surgery only decreases the number of soldiers in the enemy's army that we have to kill. And the only way to get rid of the ones that are left are with radiation and or chemotherapy. And there are a number of different kinds of chemotherapy. There's whole radiation therapy. There's whole brain radiation therapy. There's something called intensity modulated radiation therapy, or IMRT. There's focused radiation called radiosurgery or stereotactic radiosurgery, and all of those fall within Dr. Williams' expertise, and he'll explain those to us a little later. And then there is chemotherapy as well. But the key, as I mentioned before, is surgeons don't cure malignant brain tumors. We can cure benign brain tumors if we can get them all out, but we don't cure malignant tumors. Okay? Radiation therapists alone often don't cure tumors. Medical oncologists don't often cure tumors. It's when we work together and capitalize on the skills that we all have that patients do best. Again, we have wonderful computers and robotics and imaging within the Marcus that I mentioned before, but those are the things that allow us to do the very best possible surgeries. And I'm not going to spend a lot of time, but I am going to mention a few brain tumors that you commonly see and what we do about them. As I've mentioned, the most common primary brain tumor is called a glioma. They grow from cells called astrocytes or oligodendrocytes. They're the supportive cells of the brain. And most commonly, 90% of them are astrocytomas. And astrocytomas are graded through two different categories, either the World Health Organization or another one called Kernahan's. But basically, they identify 4 grades. One, which is the only potentially benign astrocytoma, usually occurs in children, and if you can get them all out, you can cure people. Grade 2 tumors are called low grade. Grade 3 tumors are called high grade or anaplastic tumors, and grade 4 tumors are called glioblastoma. So you can hear if someone says, I have an astrocytoma, this is the word the doctor gave me, it can be anything from surgically curable up to very aggressive, requiring radiation and chemotherapy and even research protocols to try to stay on top of. And it's our job as a group to explain exactly what these things mean and how they're best treated. And the treatments are very different. As I mentioned, with a grade 1 tumor, if we can take it out, we've cured the patient. With a grade 2 tumor, usually we do surgery, and not always do we do even radiation. Sometimes we just do surgery and watch it and see if it changes, and only do something if it should grow. But for grade 3 and 4 tumors, we always use surgery and radiation and chemotherapy. This is a picture of what an aggressive astrocytoma looks like on an image. I'm sure John will show us more, Dr. Weiner will show us more about it, but you can see that big, nasty-looking white ball up there, and the dark around it is swelling. And that's how we determine what and how to treat the patient and what kind of operation we do to treat it. And again, the numbers are very, very different, okay? Everybody wants to know, well, what does it mean if I have a brain tumor? Well, if you have a pituitary tumor, if you have an acoustic neuroma, if you have a meningioma, most of the time you're going to live a normal life expectancy because you're going to get in the hands of somebody like Dr. Levine or me, and with the kind of equipment and surgical skills that we have, we cure those tumors. But if someone comes in with an astrocytoma, they can have a 90+% long-term survival rate, or with a highly malignant tumor, it can be very low unless we start doing these much more aggressive interdisciplinary approaches. I'm not going to go through all of these except to say that tumors like pituitary tumors, tumors that can be treated surgically, they can have their effect by pushing on the nerves to the eyes and causing problems with vision. This is a picture of a pituitary tumor here. This is a picture of using an endoscope, and this is a picture of what we see when we're operating through the nose, taking these tumors out, and what you can see here is that ball's gone. And the patient's vision, although I would hope you don't know how to interpret these, because I don't, and if you do, then you're way ahead of me, but they're normal. The vision is returned to normal. And when we can't surgically remove them, we have tools like stereotactic radiosurgery that Dr. Williams will talk about that allow us to better treat them. And there are a lot of other brain tumors, but those are sort of the most important. As I mentioned, metastatic tumors, when tumors metastasize to the brain, if they're large or if they're causing symptoms, we surgically remove them. In addition to the surgery, or if they're small and not causing symptoms, then radiation alone can treat them. But what's most remarkable is that if you do something like radiation or what we call stereotactic radiosurgery, you can take people who have a life expectancy of weeks and turn it to months or years. And so with a minimally invasive treatment like that, we can get long-term, high-quality survivals. So this is all I want you to remember. 1, all brain tumors are treatable. 2, many brain tumors are curable. There is an interdisciplinary approach that is required for optimal care. And that's one of the things we're bringing to this area for the first time. That is, I don't treat brain tumors alone. Dr. Weiner doesn't. Dr. Williams doesn't. We all treat them together. And we have here state-of-the-art equipment, nationally recognized doctors, and this interdisciplinary patient-centered approach to ensure the very best care of brain tumors, not here, not in South Florida, but anywhere. That's what I've committed my career to. That's what I know everybody else at this panel has committed their careers to. And with the gifts like we've had from the Marcuses and the other donors, we've been able to draw this kind of wonderful expertise here and work together with the finest physicians to be able to give people what it is we do as doctors. Okay? Technically, I could remove surgery, I could remove tumors. Technically, I can suture up the scalp. But the one thing that all of us do every single day is to give people hope. Thank you very much.
Good evening. Thank you for all coming tonight. I will carry on what Dr. Levy has started, and I will try and move through the slides quickly so we have time to have questions from all of you. So, as Dr. Levy mentioned, I'm Nick Levine. I have a fellowship in skull-based surgery, and I'm going to talk a little bit about what skull-based surgery is and how we work together to treat these conditions. So skull-based, a frame of mind. So to show you some examples, the tumor is here. That's when the tumor is taken out. Large tumor after when the tumor is taken out. Large tumor enveloping the blood vessels. That's after the tumor is taken out. I chose to show you resectable tumors, but I think what you should take away from this is not all tumors are managed surgically. But since I'm a surgeon, I decided to show pictures of surgery. The key point with skull base is, what is skull-based surgery? So skull base is really an appreciation of anatomy. All of us will remember our medical school days and our days and hours in anatomy education. And skull base grew out of that. It was a way of approaching surgery in difficult locations, areas where you couldn't get to easily. So it's a collection of surgical approaches to access challenging areas of the head and neck. So at the anywhere from your chin up at the base of your skull. And it's really a convergence of specialties. We draw upon the knowledge of neurosurgeons, head and neck surgeons, or ear, nose, and throat surgeons, plastic surgeons, because many times these tumors are very large, space-occupying tumors, and when you take these out, you need to reconstruct the bone you have taken away, the musculature you may have resected. Ophthalmologists, that's beforehand and after in terms of treating people, because many times, whether it's a benign or malignant tumor, you can have deficits, which means you have problems with some function beforehand or after. Neuro-Oncologist, radiation oncologist, and radiologist. And this is just to name a few. And I view it as it's quintessentially a team sport. I view it as I'm just one member of the team when we see this type of tumor. So it lends well to the idea of everyone working together for a common cause, which is taking care of the patient. So what makes it a skull-base tumor? They're tumors that originate from or extend into the skull base. What's the skull base? Well, it's everything in back of your eyes, between your nose, all the way to the back of your head, right at the bottom of your head. It can be benign and malignant tumors. Even benign tumors can cause symptoms or threaten the health and well-being of a patient, and Dr. Levy alluded to those symptoms earlier. Skull-base tumors are classified by the location in the head, so the tumor site, or by the cell structure and identifying characteristics, so a type of tumor that occurs in that area. As Dr. Levy mentioned, location is everything. It is like real estate. And if we look at it, I use the term skull base. I use the term skull base because it encompasses all of these different areas. So your sinuses, your throat, your orbit, which is where your eye sits, the clivus, which is the bone at the base of the skull above your spinal column. And then we get into all the different spaces or fossas that are at the base of the brain, what your brain sits in. And those taken together form what we call skull base. The number of tumor types is far greater than what I will show you. The point of this slide is not for you to read everything and know every tumor on it, but this is to give you the idea and to understand that we're not just treating one tumor. It can be a tumor from anywhere in the body, so like we talked about metastases. It can also be things, as we talked about, pituitary tumors, meningiomas. So you hear about someone having like a tumor growing from the covering of their brain. That can happen up high or down low. When it happens down low within the skull, it's much more difficult to approach because you have all the critical structures at the base of the brain surrounding it. That includes nerves that control your eye movements, swallowing, your facial function. It also includes all the blood vessels that we talk about when people have strokes. If those blood vessels are damaged by the tumor or damaged by taking the tumor out, that can also result in difficulties in managing someone's disease process. As I said, the list goes on. And I also want to tell you that, you know, we sometimes group tumors into this class altogether, but there are other conditions. So there are things like fibrous dysplasia at the bottom of this list, where people have abnormal growth of bone, and that abnormal growth of bone is not a tumor, but it's growing in a manner which causes the symptoms that Dr. Levy mentioned about compression of the brain or pressure within the brain building up. So diagnosis and treatment, we really tailor every modality. Whether it's an angiogram looking at the blood vessels, an MRI, or a CT scan. The MRI shows us the soft tissue, the CT shows us the bone. And we develop treatment regimens that are specific to the tumor type and specific to the patient. And that goes back to why we have a team when we do this, because everyone brings the information they have to the table and we offer the best care together. And as I just said, surgery, radiation therapy, chemotherapy, it's combination. And each of those tumors has a different combination of those therapies. In surgery for skull-based tumors may involve either open or minimally invasive techniques. So minimally invasive is a catchphrase. It means trying not to destroy normal anatomy, trying to provide the smallest access to the largest tumor. And that can be through a keyhole, so you think of trying to peer through the old keyhole where if you got your eye close enough, everything would open up once you got through that keyhole. Endoscopy, so the images Dr. Levy showed of pituitary surgery, we use endoscopes and go through the nose or the base of the skull to resect tumors. The image-guided surgery, the computers help us travel through and look at the anatomy as we're working so we confirm not only what we see with our microscope or our endoscope, but we see it on the imaging. And then, of course, having intraoperative CT and intraoperative MRI. It allows us to check everything and do everything the way we would want it done for our own family at the time we're doing it. So there's no bringing the patient back afterwards saying, we could have gotten a little more or we should have done this. You're able to assess it right at that point and do it. And that is extremely valuable because as good as we think we are, as good as we are any day of the week or any given Sunday, we always need some sort of check, and having that check in the operating room is incredible. So I will end by saying we truly do have it all, and we look forward to working with all of you in the community. Thank you.
Hello there. How's everybody doing? We're almost done. Well, I would like to introduce myself. My name is Sebastian Espinosa. I am a neurologist with fellowship training in epilepsy. Epilepsy is my thing. You know, I'm very good at treating epilepsy, and my collaboration with the oncology program is to treat our patients with brain tumors and seizures. Just to show you here, you know, this is one of the most potent tools we have. One is the EEG, which is a brainwave test, and of course the MRI. You can see that patient is a patient of mine who had glioblastoma multiforme. The patient was having ongoing seizures coming from the temporal area. I don't know if this pointer doesn't work, but I'm going to use the pointer here in the computer. And as you can see, this area here is the left area of the brain, which is opposite to what you're seeing. And if you see here up in the top, this is the EEG that points to the temporal area. And you can see these waves that are very sharp. We call them epileptiform discharges, that they come grouped together and they form a focal seizure. This patient, when she was having the seizures, she was having a speech arrest. So that's what I do. My collaboration with the oncology program, the neuro-oncology program in our center, is to address the needs of our patients with epilepsy and seizures. I like to start by always recognizing the professors and the professors of my professors. And Dr. Jackson, he already picked up on the fact in the 19th century that patients with brain tumors will have seizures. And now we know that many times our patients will come to the ER or will present out, you know, in places at home or in the movies with a seizure. We take them to the ER, we do a CAT scan or an MRI, and we find a tumor. So a seizure is a very important sign in the diagnosis of brain tumors and per se of many neurological diseases. Depending on the case series that we looked into, seizures can present in patients anywhere from 30 to 75% of the cases. It varies from tumor to tumor, from types of tumors, etc. So there's not a pathognomonic tumor, but there are some that are more prone to give seizures, like the oligodendrogliomas. It's very typical for a patient with an oligodendroglioma that is close to the cortex to present with a seizure. The seizures, most of the times, because these tumors are in one part of the brain, they present as what we call focal seizures. Patients will have repetitive movements of one side of the body, or they can also have changes in mental status. We call them complex partial seizures. Whenever patients will have changes in their cognition, that they will not make sense, that they forgot things for a small period of time and they go back to normal. So those are things that makes us worry, and we get the appropriate evaluation, treatments, EEGs, and MRIs. We know some things, but we don't really know why the tumors produce the seizures or why the seizures. There are many mechanisms that we have described. There are many things that we know. Sometimes we think, of course, is the location. We think that those tumors that are close to the temporal lobe are more epileptogenic than those who are in the occipital lobe. We know that the frontal and the temporal lobes are more prompt for seizures. Then there are characteristics ill cells of the tumors that can make the surrounding neurons susceptible from causing seizures. So how do we treat the seizures? There's treatment for these seizures in our patients with tumors. The main treatment that we have are seizure medications. We know that our patients, whenever they get a seizure medication, they get seizure control in a good amount of times. But some of them, because there's a structural lesion, they don't get control just with seizure medication alone. In some patients, after they have failed multiple seizure medications, there are options such as doing surgery. And that's how we collaborate with our colleagues, the neurosurgeons. We do video EEG, we do corticography, which is basically an EEG in the top of the brain once we are in the OR, and we can find and look for the areas that can cause seizures and take them away without causing deficits. So like Dr. Levy showed in one of the slides, there are lesions that can cause seizures, and we can do that in our center. If there's a patient who has refractory epilepsy due to a brain tumor, we don't only stay and we just give seizure medications, we have other aggressive measures that can improve the quality of life of our patients by controlling their seizures. So here's the same patient, as you can see, basically where a patient with glioblastoma. In this patient, actually, we ended up doing surgery because we could not control the focal seizures. The patient was on 2 or 3 medications. The patient was having ongoing focal epileptiform discharges, that we call them PLEDs, periodic lateralized epileptiform discharges, and the patient was having at least one focal seizure that lasted about a minute or two, 3 to 4 times per hour. So in this patient, after we tried multiple medications, we did surgery and we were able to control those seizures. With this in mind, I'm going to end, and I would like to thank you for your attention, and I will be happy to entertain questions after my colleagues finish with their presentations. Thank you.
Good evening, everyone. Dr. Williams and myself are what I call long-term residents of this institution. We've both been here close to 30 years. I'm the director of neuroradiology. My name is Dr. Weiner. I'm going to be very brief and to the point because I realize that we're running out of time. And looks like, no one's shown you a picture of it yet, so I thought I better do that. That's what we have outside. The goals of imaging are pretty simple and basic. We want to first detect the disease, then we want to characterize it, and then we try to show what the extent, exactly where it is. That determines what the plan may be to intervene. And then once some interventions have been done, then we're going to be following them with imaging typically to see whether the tumor is growing back or it's stable. As far as imaging modalities, we have, of course, everyone knows about CAT scanning and MRI. In a subset of cases, X-ray and angiography. Angiography is where we actually put a catheter inside of a vein or an artery of the body and we take pictures or actually do therapy. And then in a small subset of patients, nuclear medicine techniques, which include PET scanning and SPECT, where we inject radioactive isotopes into the body. And this allows us in some cases to look at the physiology of the tumor or if there are specific types of chemical processes that wouldn't be apparent trying to see just anatomy with CT or MRI. When it comes to neuropathology, CT tends to dominate in the acute care and emergency room setting, and more often than not, we end up doing MRIs in virtually all neuro-oncology patients. And CT is usually just a front line in the emergency room to make sure we're not dealing with an acute emergency. There have been a lot of advances in neuroimaging. When I was in medical school, MRI was just coming out and CT had just come out. And I can tell you, I've seen, when I was in training, it took about 20 seconds or a minute to reconstruct one image. Now we can reconstruct anywhere from 50 to hundreds of images in a second. And obviously the spatial resolution, how fast we can acquire the data has gone up tremendously. And there are many new novel ways that I'll just touch upon. Not everything is tumor. Patients don't come into an emergency room or a doctor's office and say, I have this. Sometimes they actually do. They'll actually tell a doctor, this is what I have. You don't believe me? But more often than not, they just come in with a symptom. And in this patient, it was a young patient with numbness. Based on the location and the morphology of the lesion, this is a classic appearance of multiple sclerosis. It's not a tumor in the spinal cord. And you can actually see the actual normal structure of the gray and white matter of the spinal cord, and this blotch here, this little thickened white area, is actually an MS plaque. And you're seeing it here in another plane, in the sagittal or lateral plane. We do a lot of fancy things which help characterize tumors. We do things like spectroscopy. We do perfusion, where we look at the vascularity of the tumor. And on a subset of patients, we'll do what's called functional imaging, where we actually map out the function of the brain and how it relates to where the tumor is located. And this may alter the approach of the neurosurgery, and in some cases may completely change the approach. This is actually our first case here at this institution where we used intraoperative MRI. This was a young woman who had a pretty well circumscribed mass that was initially detected on CT, and the MRI very nicely shows it. And you can see here the pre-op tumor picture, and here's the post-op. You can see we got a very nice resection of the tumor, and at 3 months this lady's looking very good at this point, and we're hopeful that she will be a long-term survivor and will never have a recurrence of this tumor. Of course, she's got to be under surveillance, and if things start to recur, then we have to start doing some additional steps. Unfortunately, this is another young patient, a young man who was about 30 years old. He came in with a malignant, highly malignant glioblastoma, as Dr. Levy has shown you a few examples. And you can see on the early post-op picture there was a very nice resection. None of the normal brain tissue was damaged. The patient had no deficits. He got all the guns that we could give him, the radiation and the chemotherapy, and then he was followed. And unfortunately, 2 years later, this is what his brain now looks like, and this is now a terminal patient. And sadly, there are a subset of patients like this that we still are not able to completely cure. We may give them several years of quality life, but we're not able to cure this for good. And when they're 30 years old, it's truly a tragedy. My hope is that before I retire, I'm going to actually see this disease cured. There is research going on in animal studies. I've seen some talks in rat models where they cause this kind of a malignancy and they actually can cure it just by using drugs. But taking it from the rat stage up to the human being, it's not something that occurs in a couple of years. This typically takes generations of work. So that's basically what I have to say about neuroimaging.
Well, thank you so much. I'm Tim Williams. I'm the Medical Director of Radiation Oncology. I have 60 quick slides to go through here. Just kidding. I have like 6 slides. I feel so sorry for these folks over here who can't see. I apologize for that. We're getting this screen fixed in the near future, as Gary tells me. So I apologize for what you may not be able to see. Let's see if we can get this thing going forward here. This, of course, like Dr. Wiener showed, is our new Neuroscience Institute. I just don't know how they've done everything that they've accomplished since this program started. I think you have to realize that this Marcus Neuroscience Institute is the programmatic equivalent of an explosion. I mean, there's just an unbelievable amount of programmatic projects that have been rolled out and unfurled in this. I don't know if anybody in the country, I've been in medicine a long time, and I've never seen a place go from where we were in the neuroscience efforts to where we're aspiring to be in a neuroscience enterprise. I think Dr. Levy, Dr. Levine, Dr. Espinoza, the team that has been assembled here is just a wonderful, wonderful resource from the community. It's really a privilege and honor to be a part of it. I was sort of lucked into being in the right place at the right time. What I wanted to talk to you about briefly was our aspirations for our proton center. I'm not sure why we're projecting in such a weird way, but I think there'll be enough to see. This is our accelerator that we have downstairs, and they're pretty good machines. They can deliver high energy radiation beams in a very, very precisely controlled way to a very, very accurate target volume. We're pretty good at that downstairs. We've been doing it a long time. Our chief physicist, Dr. Shang, back there, is in the back. Raise your hand there, Dr. Shang. He's the reason I can sleep at night, to be honest with you. When I lay my head down on the pillow, I know that Dr. Shang has been making sure that everything that we do, is accurate and correct. And I shouldn't say it this way, it's politically incorrect, but it's absolutely true. Dr. Shang is Chinese. He has a fabulous story to hear someday. But I'll put our Chinese physicist up against anybody else's Chinese physicist. They're all Chinese, and they're absolutely brilliant. We're very lucky to have him. But anyway, so we're pretty good, with this stuff. And you can do this high precision stuff that Dr. Levy was mentioning called stereotactic radiosurgery on this machine. And we do some 50, 60 patients a year, perhaps something like that on it. It's a core part of our program. There's another couple of devices here that also do stereotactic radiosurgery, and the common consensus out there is that these two machines do it better. This machine right up here on the upper left-hand corner is called the Gamma Knife machine. And it was one of the original stereotactic radiosurgery devices. A brilliant person from Sweden came up with it. It was a neurosurgeon, not a radiation oncologist, but it's a radiation oncology machine. This machine down here is called the Cyber Knife, and it was also invented by a neurosurgeon. You sort of get the idea here where we're going with this. Neurosurgeons have been intimately involved in my specialty for many years, and they come up with a lot of clever innovations that are important for us. We're actually putting in one of these machines down here, the Cyber Knife machine, in our office this next year. Both these are fabulous machines, and you can get a really lively debate going in any neurosurgical meeting you'd care to drop in on just by saying, I think that the Cyber Knife machine is better, or I think that the Gamma Knife machine is better. Just randomly drop that out there, and you'd be surprised how excited neurosurgeons can get about the discussion as to which machine is better, one versus the other. But they're both quite good, and they probably are better than our current SRS platform with the Novalis accelerator that I showed you previously. And that's all well and good, and we're happy to have this machine, but that's not where our program is going to be going with ultra-high precision stereotactic therapy for brain tumors. We're going to join the likes of these other folks here, University of Florida, Washington University, Harvard, MD Anderson, Mayo Clinic, Scripps, Seattle Cancer Care Alliance, Penn. They currently have proton machines that are either in development or holes in the ground, in anticipation of completed machines. This is sort of what they look like. I know you guys can't see this, but this thing over here is called the cyclotron. And it's a big, heavy mother that's about maybe a third of the size of this room, something like that. And it's a big, fat cyclotron, and it takes protons and it spins them around really fast, 10 million times a second. It'll spin those protons around in a circle. And when they get all nice and dizzy, you peel them off the machine, and you send them down this beam line here, and then you're directing this enormous gantry. This little black thing here is the patient. I'll show you a picture of one of these gantries in a second. But these protons are very fast, but they can be bent because they're positively charged. So you take a magnet, and you can bend them in whatever direction that you want. And so they go up here, they come up when you spin them around, bend them down, and then direct them into the patient. And the fun thing about a proton is that it'll penetrate to a certain depth, and then it stops. There's no exit dose from it or anything. And so if you can control exactly how deeply you're ranging the proton, you got a really a significant physics advantage. And that's what we're after in our program here. This is the actual pictures of the machine. This is the cyclotron itself, made by, this one's made by Varian Medical Systems. It's a big round magnet, basically. These magnets are what are called superconducting, so they cost a lot of money, basically. What they are is holes in the ground into which you pour a lot of money. And so this is the device here. This is the injector, not the beamline coming out of it. The thing actually runs, believe it or not, on water. You take distilled water and you split it into the oxygen, which goes over here, and you take the hydrogen nucleus, which is a proton, and that's what gets injected into the cyclotron here and gets spun around. And this is the gantry here. You notice the person right here standing in it. And then the patient lays here on the table. The beam comes out this nozzle right here, gets directed very, very precisely into the patient's body. And this is two pictures of what the treatment room looks like. The table's robotic. This is the table the patient lays on. There's the nozzle right there. Another room looking straight into the gantry itself, although it's behind the screen here. Nozzle comes out and the patient lays on the table. It's hard to believe, but in a couple of years, maybe 3 years max, we're closer to this than people actually realize. We'll join these other institutions having our own proton facility. So little old Boca Raton Community Hospital, you know, in coordination with FAU's physics program as well. We have liaison with the Department of Physics over at FAU. We'll have a proton machine of our own that we can use, you know, to do our contribution into this wonderful program that has been created through the benevolence of our community and the fabulous faculty that has joined us here to bring this program forward. Thank you very much.